Hi, I'm Dr. Robert Parisian. I'm an orthopedic sports medicine surgeon at the Mount Sinai Health System in New York City. I provide team and event coverage for U.S. Ski and Snowboard Team, USA Fencing, as well as the NYC Marathon. And I was a player physician at the U.S. Open in 2022. So I want to discuss the management of acetabular labrum as it is concerned with sports-related hip injuries and pathology. So these are my disclosures. Most of these related to different editorial boards and committee memberships that I'm on. I'm a member of the Council of Delegates of the American Orthopedic Society for Sports Medicine, associate editor for the Journal of Cartilage and Joint Preservation. I'm on the editorial board for arthroscopy and our arthroscopy sports medicine and rehab, as well as Journal of Sports Rehab. I'm on the research committees for both the AOSSM as well as ANA, our Arthroscopy Association, Surgical Skills Committee for ANA, and I'm a committee member for several other committees, including the New England Orthopedic Society, Society of Military Orthopedic Surgeons, and the Eastern Orthopedic Association. And then I'm involved with several nonprofit organizations. So I believe that anytime you're talking about a topic, you really need to know where the individual is coming from that is discussing this particular topic. So here's my education and background. I did my orthopedic surgery residency training at Boston University, my first sports medicine and shoulder surgery fellowship at Boston University, where I was a team physician for Boston University Athletics. I also did my second fellowship in sports medicine and cartilage restoration at the University of Pennsylvania and the Penn Center for Advanced Cartilage Repair. And then a third fellowship in minimally invasive hip surgery at Harvard Medical School. And this is where I did both open and arthroscopic hip surgery. And now I really specialize in arthroscopic surgery of the hip as well as sports medicine. So arthroscopic surgery of the shoulder and the knee as well. So getting into the topic of the management of the acetabular labrum, this is the layered concept that was initially introduced by Dr. Kelly. And the part of the layered concept that we're going to focus on for this discussion is going to be the acetabular labrum, which really provides static stability to the hip joint. So this is the inert layer of the layered concept theory of hip pathology. Now, looking at the anatomy, starting from the beginning here, the acetabulum is really made up of the cotyloid fossa and the lunate cartilage, as you can see an en face view there, and the image on the top. Cotyloid fossa is in the center, and the lunate cartilage is really about 70-degree rim around there. We don't have any cartilage in the inferior aspect of the acetabulum because that's where the transverse acetabular ligament lies. The vast majority of our acetabular labral defects are going to be in that sort of 12 to 3 o'clock range. And we'll get into reasons as to why this might occur there. The acetabular labrum is a rim of tissue that, again, surrounds the acetabulum in about a 270-degree area. Looking at the anatomy further, number 3 here is labral width. So when we talk about the labrum, is it normal? Is it hypotrophic? So is it enlarged? Is it smaller, or is it hypertrophic? Is it enlarged? We're really discussing the width here, and that's number 3, and that measures from the edge of the acetabular rim and out to the width of the acetabular labrum. Number 1 is measuring the capsular recess, and number 2 is labral thickness. Now, if we look at the chondrolabral junction in the arthroscopic image there, that is where the probe is between the labrum and in between the articular cartilage. That's the chondrolabral junction. And in the acetabulum, this is confluent, this region here. But the chondrolabral junction does provide a little bit of a weak zone. And why is this the case? Well, the chondrolabral junction is about 1 to 2 millimeters thick with regards to its articular cartilage, whereas the rest of the thickness of the articular cartilage in the acetabulum is about 1.26 millimeters thick on average. The posterior labrum does have collagen fibers that are perpendicular to the acetabular rim, whereas the anterior labrum, where we do encounter our acetabular labral pathology most often, the collagen fibers there are parallel to the rim. And this may create a vulnerability to increased shear stresses in that region. And then again, the chondrolabral sort of transition zone there of weakness has a variable arrangement of collagen fibers. Now, the overall function of the acetabular labrum is to deepen the acetabulum, to deepen the socket of the hip joint. It increases the acetabular surface area. It increases the acetabular volume. It decreases contact pressures, and there are proprioceptive and nociceptive fibers within the acetabular labrum. This is a nice cadaveric analysis that really looked at the circumferential strain across the labrum during hip motion. And what did they find? Well, they found that peak strains were identified at 90 degrees of flexion adduction and internal rotation. And this is our typical anterior impingement test, deflection, adduction, internal rotation. And this is where peak strains were identified in this cadaveric model. Another nice cadaveric analysis was looking at the contribution of the labrum to hip stability. And they found that a partial complete labral resection reduced the distractive forces by about 70%. Now, importantly, labral repair, going in and fixing and repairing that labrum, at least in this cadaveric model, restored the stability of the hip joint. And we'll get into the reasons why for this. So acetabular tears can be secondary to typically things that we call impingement. And impingement exists with regards to cam impingement, as you see there, with a little with a bump and a lesion on the femoral head neck junction. It's an asphericity of the femoral head. You can also have pincer impingement, which is over coverage of the acetabulum, and then a combined type of impingement, which is both cam and pincer. In the radiograph you see there, on the right, that right hip, that is a dysplastic hip, and dysplasia, where you have inadequate coverage of the socket, the acetabulum over the femoral head, that can also lead to labral tears. Now, there are two types of lesions depending on the insulting factor, whether that be hip impingement or hip dysplasia. And so hip impingement results in sort of this outside-in lesion where you have the cam morphology or cam lesion will come up and engage the labrum of the acetabulum in flexion, and that causes tearing of the acetabular labrum, as well as some delamination of the adjacent articular cartilage and the chondral labral junction. And you get sort of this outside-in chondral flap morphology and mechanism of injury in this hip impingement. With regards to dysplasia, that's a bit different. So in a dysplastic hip, you have a more vertical force vector, and you can have edge loading of the acetabulum and the acetabular labrum. This can result in hypertrophy of the acetabulum of the acetabular labrum, because it's seeing increased force. It gets enlarged to address this force secondary to Wolff's law. So the inside out lesion of dysplasia, you result in this sort of shear forces, and you get this inside out flap, and you really get this disruption of the articular cartilage. You can have loose damaged articular cartilage secondary to dysplastic mechanism. Classification of labral tears. So the Beck classification was looked at very closely by the Anchor group, and basically 4 hip arthroscopy surgeons analyzed 40 arthroscopic videos, and they found substantial inter and intra-relator reliability with regards to the Beck classification on classifying acetabular labral tears. So it seems to be a good classification system to utilize. Now, this Venn diagram looks at the different ways in which we can address labral pathology. And I like it because the vast majority of the labral tears are being repaired these days. And again, these are younger patients that are active, that are undergoing their initial primary hip arthroscopy. They may have an unstable labral base. They do have adequate labral tissue that can be repaired. And the goal is to really recreate that suction seal and restore that suction seal. We also have good outcomes with regards to labral debridement in certain cases, and then augmentation reconstruction we'll get into, but those should be reserved for lower percentages of cases, and really in the reconstructive phases when you're in your revision hip arthroscopy settings. So looking at debridement versus repair and 10-year outcomes, Dr. Philippon and his colleagues analyzed this. And what did they find? Well, they found that there were significant improvements in patient-reported outcomes with both labral debridement and repair for hip arthroscopy. Those patients that didn't have as great of an outcome, or patient factors that portended a worse outcome, were really related to the articular cartilage. So patients that were a bit older, those that required an acetabular microfracture, which is a cartilage restorative procedure to address focal cartilage defects in the acetabulum. And those patients that had joint space narrowing of less than 2 millimeters, once again, a surrogate for the quality of the articular cartilage. Now, labral repair. What is labral repair? So labral repair is when you go in and you place anchors and sutures around the labrum to stabilize the labrum. You go ahead and you prepare the acetabular rim with a burr to expose bleeding bone. That is the top left photo. There is the burr preparing the acetabular rim. Suture anchors then of various materials. It can be some sort of a plastic like a polyether ether ketone, or it can be all suture can be utilized. Also, you can have different suture techniques that can be utilized. You can do a simple loop technique around the entire labrum itself. You can do a labral-based fixation, inverting or everting, depending on the situation. Different techniques to repair the labrum are utilized. However, the goals of all of these techniques and different fixation devices is to really reestablish the labral base, stabilize the chondrolabral junction, and restore the suction seal of the hip. So this video is an arthroscopic video where I am utilizing the arthroscopic burr to prepare the acetabular rim. The capsule is behind the burr that's being protected by the sheath of the burr, and the labrum is closest to us, you can see, and the acetabular rim is being prepared so you can place your anchors in there. You want a stable base for labral fixation. You also want to create a bony bleeding bed to help encourage labral repair. And so again, this is just preparation of that acetabular rim during arthroscopy for labral fixation. Now, in this video, the all suture anchors, I utilize knotless all suture anchors for my labral repairs. They have already been placed, and this is just the suture has been passed around the labrum in a simple loop technique. And here is just tensioning of that suture around the labrum to stabilize the labrum, again, utilizing a knotless suture technique. So you can see the tensioning there on the labrum. This is stabilizing the labrum to the rim of the acetabulum and hopefully decreasing the symptoms for the patient and recreating that suction seal for the femoral head within the acetabulum. Now, this is following repair of the labrum, and the probe is demonstrating a stable acetabular labrum, really in that anterior and anterior superior portion, as we noted before, in the 12 to 3 o'clock position. So again, a nice stabilized acetabular labrum after simple loop fixation as in place with all sutured knotless technique. And this is when traction comes off of the hip joint after the acetabular labral repair. So now the femoral head comes back into the acetabulum, and you can see the restoration of the suction seal here as the femoral head is being reduced back into the acetabulum, and that suction seal is being recreated after you repair the acetabular labrum. And now we're going to enter the peripheral compartment for our femoral osteoplasty. So what are the outcomes for labral repair? Well, there are several studies out there, but I wanted to choose these because there's really high level athletes, and there are many more out there, but they're all very consistent with these statistics. Return to sport was identified in 94 and 88% for both recreational and high level athletes, respectively. 95% when evaluating professional baseball were able to return to sport with a mean career length after their labral repair of 3.6 years. And then when evaluating professional football players, nearly 90%, about 87% return to play. Linemen appeared a little bit less likely than other positions to return to play following an arthroscopic labral repair. Now, when looking at the hypotrophic labrum, when the labrum is a bit smaller, less than 4 millimeters, for example, as you saw earlier, really the jury is still out. So Dr. Hume and his colleagues identified inferior outcomes for repair of a hypotrophic labrum as compared to a normal labrum, whereas Dr. No and his colleagues evaluated this and found that you had comparable or similar outcomes for repairing a hypotrophic labrum as compared to a normal labrum. So really, the jury's still out. We need more data in this regard. Now, the wave sign. The wave sign is a very important pathologic concept to be aware of, and this is when you have delamination of the chondrolabral junction without a discrete labral tear. So again, that mechanism, that outside-in lesion, you have engagement of the cam lesion, it engages the labrum, it causes delamination of the articular cartilage and the chondrolabral junction. The wave sign is when you have that delamination without a discrete tear. So this video, again, this arthroscopic video demonstrates the wave sign. As you can see here, when I'm probing the articular cartilage, you can see how it's loose. There's a bit of a waviness to it. And then when you push down on the acetabular labrum, you can see that wave and how it sort of bubbles out there. That is the wave sign. It demonstrates that the chondrolabral junction, without a discrete tear of that portion of the acetabular labrum, that chondrolabral junction is really unstable and it's loose, and it can be creating symptoms for the patient. And so we know as data has demonstrated that performing an acetabular labral repair in the setting of a wave sign without discrete tear of the labrum doesn't improve patient outcomes to just stabilize that chondral labral junction with a labral repair. So back to our Venn diagram, we've discussed our labral debridement and repair. Now moving on to reconstruction. So this was first described and introduced by Dr. Philippon in 2010. This really should be in the setting of revision cases, so less than 1 to 3% in the primary setting, and probably in that range, just generally speaking. This is when you have an irreparable labrum. You may have an ossified labrum or a severely hypoplastic labrum that doesn't lend itself to a repair, and that's why I mentioned those studies earlier about repairing a hypoplastic labrum, why that's so important, as we need to have more data to support that. And then again in the revision setting. However, and this is an example of a labral reconstruction. You can see allograft tissue that was utilized. So you use cadaveric tissue. You go ahead and you shave all of the native labrum off of the rim of the acetabulum, place anchors around the acetabulum, and you utilize allograft tissue. I prefer posterior tibialis, but you can also use anterior tibialis and fascia iliaca and other tissue to recreate the acetabular labrum in a reconstruction. And this is the suction seal that has been recreated between the femoral head and the acetabulum following an acetabular labral reconstruction procedure. Now, outcomes of labral reconstruction. There really is at this point a paucity of data when it comes to the primary setting. It seems to be in patients that require acetabular labral reconstruction in the revision setting for all those other factors that they do have some good clinical outcomes. However, in general, we have a paucity of data right now, and there's some evolving literature on labral reconstruction outcomes. Now, labral augmentation is another way in which we can reconstruct the acetabular labrum, and this was introduced by Dr. Philippon, where you maintain, rather than the labral reconstruction procedure that we described previously, here you do not debride all of the native labrum. You maintain that native labrum that's there, even though it's irreparable, but then you do a labral reconstruction over the top of it, and you incorporate the native labrum with the allograft tissue. And this is a labral augmentation. Dr. Philippon looked at this and found that there was improved clinical outcomes with labral augmentation as compared to reconstruction. However, again, there's still a paucity of data, and we need more study to evaluate this. Now, other considerations beyond labral tears or circumstances that you may encounter when addressing acetabular labral pathology are cartilage defects. You can see here, this is the acetabulum on the left. That's my probe there. I am probing underneath a large chondral, full thickness articular cartilage fragment. And this happened because the patient is experiencing some delamination over time of the acetabular labrum, which caused some delamination of the acetabular cartilage and this full thickness chondral flap that's here. Once that flap was debrided, the full thickness chondral defect is identified. Here we would call this an ICRS grade 3B/C. It's all the way down to the calcified cartilage and certainly down to calcified cartilage and the subchondral bone plate, but the subchondral bone plate remains intact here. And so there's different considerations for this to do a cartilage restorative procedure. One of those options is that you can do some subchondral drilling. So this is a curved guide, and I'm placing a drill through this to drill holes through the subchondral bone plate, so you can have egress of bone marrow elements that have growth factors within them and mesenchymal stem cells. And here you can see the egress of those bone marrow elements through the subchondral drill holes to promote some fibrocartilaginous filling of this full thickness chondral defect. And you can see the sutures above there are what was utilized to repair the labrum. Now, once that was completed, the joint was dried, and we elected to utilize a allograft extracellular chondral matrix that was placed in the cartilage defect. Now, this extracellular chondral matrix is utilized to help. I'm going to fast forward this video here. And you can see the extracellular chondral matrix here is being placed in the full thickness chondral defect. And this is a cartilage restorative procedure to restore this patient's cartilage in that full thickness condylar defect. And so there's this spatula device that can be utilized. The extracellular matrix can be mixed with either whole blood or PRP, which is platelet-rich plasma that has growth factors in it, and then it is placed right in the portion of the defect after a subchondral drilling, which is what I prefer as opposed to microfracture. Subchondral drilling is performed because I believe it's less traumatic to that subchondral bone plate. So then now you can see this being performed, and then you place fibrin glue over the top to help stabilize this extracellular matrix. So again, that was management vestibular labrum with further consideration for cartilage restoration. So thank you for your time.